Hello, everybody, and welcome to another great little lunchtime webinar. I see a lot of the usual suspects are on the Zoom call today, so thanks for joining. It's good to see everybody. So this one's, a hot topic, natural ways to reduce high cholesterol. So let's roll up our sleeves and get our arteries so that the blood can flow. So in a nutshell, about 41% of Canadians have high total blood cholesterol. That would mean a cholesterol above 5.2 millimoles per liter. In the United States, they use milligrams per deciliter. That would be over 200 milligrams per deciliter. High cholesterol is a cardinal risk factor for heart disease, stroke, and other life-threatening cardiovascular conditions or problems. It's not the only risk factor, but it's a risk factor, as you will see. To convert milligrams per deciliter into millimoles per liter, the conversion factor is 0.026. So that's really how 200 milligrams per deciliter becomes 5.2 millimoles per liter. The most ideal total cholesterol, by the way, is not 5.2. It would be 3.9 millimoles per liter or less, and I'll show you how most people can get there. But approximately 5% of people are born with very strong genetic defects like LDL receptor defects, which I'll show you, which is responsible for sky-high cholesterol levels in these individuals. And the only way they can get their cholesterol down is really with statin drugs. And if they don't do that, then heart attacks are inevitable by age 60, and they begin occurring between age 35 and 40. So, I think that statin drugs personally are overprescribed, but for a certain subpopulation of people with really strong genetic defects, and I will show these to you, or they're in a real high risk category for cardiovascular disease. They've already had bypass surgery or other cardiovascular problems. They've had a stroke in the past. Or they have atrial fibrillation. There's an argument for using statin drugs for these people, definitely. But for most people who just have cholesterol that's trending higher, they can get their cholesterol down into the ideal range through diet, lifestyle, nutritional medicine, if they really want to. But when you show people how it's done, truthfully, most people are not willing to do what it takes, and so they end up on drugs. But a lot of people are never shown what I'm about to show you today to understand how to get your cholesterol down. There are a certain percentage of people who would be willing to put the effort in to avoid drug therapy because the drugs can come with some potential side effects, as we will see. So, when you're born, you don't have plaque in your artery, right? The lumen of the artery is wide open. And then over time, this sort of yellow foam cell plaque starts to appear. And then over time, it can lead to significant occlusion and blockage, which of course leads to heart attack, ischemic stroke, peripheral vascular disease, shutting down of your kidneys. This is a histological slide. Here's the lumen of the artery. Here's what's left. And these are all the atherosclerotic plaque. These are basically foam cells, which we'll talk about. So this foam cell material that you see here these are really white blood cells, monocytes, that infiltrated an area of the artery where there was already some stripping away of the endothelial lining. And the macrophages or the monocytes come there and they morph into macrophages. Then they start to ingest the bad cholesterol, the LDL cholesterol, and they sort of blow up. They become like the Michelin tire man, and they just keep ingesting more and more LDL cholesterol until they die inside this plaque formation as foam cells. So the foam cells here are cholesterol-laden macrophages. That's really what they are. And you also have connective tissue and smooth muscle growing from the basement membrane of the blood vessel, growing into the lumen of the artery, forming sort of these beams or things that the foam cells can stick to. So this is the Widowmaker. So if you look at the heart circulation, here you see the left coronary artery. Then you have this branch called the left anterior descending artery, which serves the front left wall of the heart. And it's blockage of this left anterior descending, or the LAD, that leads to a lot of sudden death heart attacks. So if you look at it on an angiogram, here you see the left anterior descending, and here you see total blockage, or 95% blockage of the artery. You also see it here. You see this occlusion here on an angiogram. And in 25 to 40% of cases, there are no symptoms. I feel fine. And then all of a sudden, they're mowing the lawn and they just drop dead. Oh, he was just struck down. So just how the person feels is not an indication of whether or not they have cardiovascular disease. Because in 25 to 40% of cases, the first symptom is sudden death. So knowing what the risk factors are in advance is really the right way to go about this. So I'll show you how you put that profile together. So in the formation of the atherosclerotic plaque, and I only have, an hour with you today, so I can't get into all the heavy details, but generally speaking, over time, due to high blood pressure or high homocysteine levels, or just the aging process, turbulence in the artery, you strip away some of the lining cells in the arteries, especially where there's bifurcations, where there's more turbulence. It strips away the endothelial cells, so you get denuding or arterial injury. And then that becomes just the same way if you had an injury to another part of any tissue in your body. White blood cells through chemotaxis come to the area, especially monocytes. They morph into macrophages and they go into the subendothelial space. And then once they're there, they start ingesting the bad cholesterol, the LDL cholesterol. They start consuming it and they start to blow up and become these foam cells. And then these foam cells, which are really just cholesterol-laden macrophages, start to secrete all kinds of inflammatory cytokines, which produce blood vessel inflammation. And these cytokines go to the liver and they increase the release from the liver of C-reactive protein. So if you know the person's blood level of C-reactive protein, if they don't have an autoimmune disease or cancer, you're pretty certain at that point that the CRP level being high is a reflection of blood vessel inflammation. It's a risk factor for cardiovascular disease. So the LDL cholesterol in the bloodstream, if it becomes damaged by free radicals or gets oxidized, then it's even more inclined to be ingested by the macrophage. And then over time, you get more and more cholesterol inside the macrophage, forming a foam cell. And what's interesting about macrophages is that they have what are called scavenger LDL receptors. That means that as they ingest more cholesterol or LDL cholesterol, there's no feedback loop for it to stop doing that. With other cells in the body, once they have all the cholesterol they need for their own purposes, which we'll look at, they stop ingesting LDL cholesterol. But the scavenger LDL receptor on the macrophages, there's no stopgap measure. So it keeps ingesting. If the LDL cholesterol in the bloodstream is high, more and more of that gets ingested by the macrophage or internalized by the macrophage. And the macrophage gets larger and bigger and larger. Eventually, it suffocates to death just eating so much LDL cholesterol. Like the Michelin tire man, it forms this gigantic foam cell inside the subendothelial space, forming the fatty streak and the atherosclerotic plaque. What we know for sure is that as total cholesterol rises, especially LDL cholesterol, as your total cholesterol rises, the risk of death from coronary heart disease increases pretty much proportionately. The best place for your total cholesterol to be, according to the Framingham Heart Study, which has been following residents of Framingham, Massachusetts since the 1950s, people who have a total blood cholesterol at or below 3.9 millimoles per liter, or 150 milligrams per deciliter, as a rule, do not have heart attacks. So when they sometimes say the person's cholesterol was normal and they still had a heart attack, that's because what's considered to be normal or what the acceptable medical range for cholesterol is anything that's at or below 5.2 millimoles per liter. But at 5.2, if you look at this graph, you see at 5.2, people are still dying of heart disease here. That's not normal. What you want is what's ideal. Ideal is below 3.9 millimoles per liter. Not everybody can get there because of certain genetic things you can inherit, which I'll show you shortly. So the next best target is to be at 4.7 millimoles per liter, which is, I think, about 185 milligrams per deciliter. As far as the LDL cholesterol, which is part of total cholesterol, as you'll see, ideally you want to have an LDL cholesterol. I want my LDL cholesterol always to be under 1.5 millimoles per liter, and it is below 1.5. Medically acceptable LDL cholesterol is 2.5. If a person is a diabetic, then they want it under 2 or under 1.8. But the best place to have an LDL cholesterol is actually under 1.5. So what is total cholesterol? Well, it's all the cholesterol in your bloodstream that's traveling around in the LDL cholesterol, the HDL cholesterol, the VLDL, which is the very low density lipoprotein, and the chylomicrons, and the intermediate density lipoprotein. I'll show you how these all sort of connect into a little storyline. Remember that the HDL is the type of cholesterol that is the good cholesterol because it's kind of like a little vacuum cleaner that pulls the cholesterol out of the artery wall, takes it back to the liver where it can be broken down and converted into bile acids, excreted through the fecal route and out of the body. Also, there's a thing called the total cholesterol to HDL ratio of all the cholesterol in your bloodstream. How much is that versus how much is the HDL? Well, the higher the HDL, the better. That means as the ratio goes lower, that's a good thing for you because that means that most of your cholesterol or a lot of it is in the HDL. So ideally, you want a total cholesterol to HDL ratio of 3:1 or lower, and lower is better. So how did that plaque end up in the artery wall in the first place? Well, primarily, this is what the story looks like. When you eat saturated fat, but I would also say trans fats and deep fried foods, as well as foods with a lot of cholesterol, when they're in the intestinal tract, as you know, they get absorbed by chylomicrons, sort of like a little shuttle bus that sort of picks up that as you're absorbing that fat, those fatty materials, goes into this little like shuttle bus. And the chylomicrons are going to deliver those fats and cholesterol to the liver. But on the way to the liver, they actually can deposit some of the fat in your fat cells, send some of the fat to your muscles, and your muscles are happy to burn fat. So going for a walk after a meal actually helps to prevent some of that fat from reaching the liver, because when saturated fat, especially and trans fats, reach the liver via the chylomicron, they go into the liver cell, and the liver cell says, what am I going to do with this fat? If I store this fat, I'm going to develop fatty liver degeneration or non-alcoholic steatohepatitis, as it's called. So the liver has to get the fat that you ate, that saturated fat, over to your fat cells so you can store it, and your fat cells will get a little bit larger. But also, if you can get the fat over to muscle tissue, skeletal muscle, cardiac muscle, smooth muscle, they all love to burn fat. If you can get the fat over there, muscles will burn the fat as an energy source just to keep themselves functioning. And so muscles love to burn fat, but you have to get the fat from the liver cells over to the muscle cells or to the fat cells. Now, because oil and water don't mix, you can't just put saturated fat into the bloodstream and let it dissolve and send it through the bloodstream. You need to package it in a way that it will dissolve in the bloodstream. And so in order to do that, what the liver has to do is build a protein shell around the outside, put the saturated fat in the middle in the form of triglycerides, and then to make it float exactly right, it needs to have cholesterol here in the intermediate zone. So even if you didn't eat any cholesterol, you ate a chocolate bar, which is loaded with saturated fat, but it has no cholesterol. It's cholesterol free. Potato chips, cholesterol free. But when those kinds of trans fats and saturated fat, when they get to the liver turns on cholesterol production. And here's the problem right here. The liver will turn on cholesterol production from acetyl coenzyme A to make the cholesterol needed for that new lipoprotein that's being formed, known as the very low density lipoprotein. So it can take the fat and transport like a little shuttle bus service. It'll now be excreted from the liver, and it'll be in the bloodstream near the fat cells. There's an enzyme, and remember this enzyme is called lipoprotein lipase, that will hydrolyze the triglycerides in the VLDL so the free fatty acids can diffuse into the fat cell and reform triglycerides, and your fat cells get a little bit larger. So now some of the fat travels by muscle cells, and the same thing happens. Lipoprotein lipase helps the fat get into the muscle to be burned. But notice that none of the cholesterol has left the very low density lipoprotein, the VLDL. So as the fat gets removed from the VLDL, what's left is a protein shell, and in the middle, you still have all the cholesterol in there. So this is where people say, I can eat whatever I want. I burn it off. I'm an athlete. I burn off the fat. I don't have to, I can eat anything I want. Look at me, I'm so skinny, 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 skinny. I just burn off the fat. But you don't burn the cholesterol that transported the fat to your muscles or to your fat cells. So when you eat these fats, you turn on cholesterol production. And the fat gets removed by the fat cells, or you burn it all, which is wonderful. You stay thin. But you still produce the remnant particle. So as the fat leaves the very low density lipoprotein, it sort of slowly becomes an intermediate density lipoprotein. And then it becomes, once a lot of the fat is gone, it becomes the LDL cholesterol, the low density lipoprotein cholesterol. And you say, well, so now what happened? Where does that go? Well, here's where it goes. It's not all bad. All the cells of the body pretty much have these little LDL receptors, also known as the coated pit. And the LDL particle will actually fit right into the receptor and get taken. The whole thing will be extracted and brought internally inside the cell. And then lysosomal enzymes will break it apart, and the cholesterol then can be used to make the cell membrane, which the cell needs to make. Steroid hormones are all made from cholesterol, this cholesterol. So aldosterone, cortisone, cortisol, estrogen, progesterone, testosterone, all those steroidal hormones are made from that cholesterol. Well, the adrenal glands and the ovaries and the testes are going to need some of that, absolutely. Some of that LDL cholesterol gets picked up by the liver, and the liver can convert some of that cholesterol into bile acids to help digest fat at the next meal. You go, that's a good thing. That's a good thing. Some of that LDL cholesterol goes to skin cells, and when sunlight hits your skin, 7-dehydrocholesterol gets converted into vitamin D. It's how you make vitamin D, through photosynthesis. A certain wavelength in ultraviolet light from the sun converts cholesterol into vitamin D. And then from there, the skin cells can release it into the bloodstream. So that all sounds great. Here's the catch. That once all the cells of the body have all the cholesterol they need, they stop making these LDL receptors. They basically shut the door to any more LDL cholesterol coming in. So now any extra LDL cholesterol that you made stays in your bloodstream for 3 to 5 days and will get incorporated, get ingested by those macrophages in the arterial areas where there's been some injury or denuding. And they'll start consuming the LDL, and they'll form larger and larger foam cells, and the atherosclerotic plaque gets larger and larger. The blood vessel becomes more and more occluded by those foam cells. Now, conversely, if you make HDL, so HDL is made as a totally separate lipoprotein by the liver. The liver will make its own HDL, secrete it to the bloodstream, and the HDL can vacuum up some of that cholesterol in the artery wall and help to reverse atherosclerosis to some degree. Not 50%, but maybe 5%, maximum 10. So you increase your HDL production when you're thin and when you do aerobic exercise. Women, when they're premenopausal, making estrogen also helps them increase their HDL. So this is a more detailed look at it. This is sort of the version of this that a primary health practitioner should know. So I gave you the high level overview, but here's how it looks more specifically, if you just give me 5 minutes of your time. When you have dietary fat and cholesterol, once it's in the intestinal tract, again, chylomicrons will be formed, and they'll transport those fats through the bloodstream. But while they're on their way to the liver, right, they're eventually going to get to the liver. If you follow that arrow all the way around to the liver, it'll encounter lipoprotein lipase enzyme in the endothelial cells around fat tissue. So some of those free fatty acids will be hydrolyzed and will go into the adipose tissue and become triglycerides. Some of those fats go into peripheral tissue, especially muscles that will like to burn the fat. So if you go for a walk after a meal, more of the fats are going to be picked up by your muscle cells and burned before they end up going to the liver and turning on cholesterol synthesis. So that's why doing some leisurely activity after you eat a meal is actually a great idea. I need to do this more myself. So, but most of the chylomicrons end up going to the liver, and because they have apoprotein E as part of their outer protein shell, that's how those chylomicrons get cleared. So genetically, if you don't make apoprotein E, it's hard to clear those triglycerides from the bloodstream, and you have very high triglycerides level. Your cholesterol level's not elevated, is elevated a bit, but you have really high, super high triglyceride levels, even though your diet's pretty good. But that can be a genetic factor leading to high triglycerides, as you will see. Then once that fat gets into the liver was going to make the very low density lipoprotein and circulate that. And again, it'll encounter lipoprotein lipase, and some of the fat will go into the fat cells. And then as the fat gets removed, some of the VLDL becomes the intermediate density lipoprotein because its density is changing. Some of those fats are going into peripheral tissue like muscle tissues. And then eventually, once the fat is removed, you're left with the LDL cholesterol particle, which is 50% cholesterol. And because peripheral tissues have LDL receptors, as I showed you earlier, that LDL will be cleared by a lot of the cells. Well, once the cells have all the LDL cholesterol they need, then the LDL will go back to the liver to be removed. But unfortunately, a lot of the apoprotein B on the outside of the LDL cholesterol sort of gets dissociated, so it becomes harder for the LDL to be cleared by the liver, so it stays in the circulation for 3 to 5 days. And that's what's problematic, is that it's circulating for a long time. So the HDL, which is synthesized in the liver, the way that the chylomicrons get apoprotein E is that the HDL synthesized in the liver donates apoprotein C2, and it's apoprotein C2 that activates lipoprotein lipase to clear fat, and also the ApoE that is required for the liver cells to clear the chylomicrons from the circulation. Same is true for very low density lipoproteins. They acquire apoprotein C2 and ApoE from the HDL. So if you have an HDL defect or you can't make ApoC2 or ApoE for genetic reasons, you're going to have high triglycerides. Even if your diet is good, you're going to need triglyceride lowering drugs like fibric acid, cholestyramine, or high doses of niacin. Apoprotein C2 is which activates the lipoprotein lipase, so you can clear the triglycerides from the chylomicrons and the very low density lipoproteins. ApoE activates LDL receptors on the liver, so if you have ApoE, that's how you're going to be able to clear LDL from the circulation to some degree, and also VLDL and chylomicrons. But if you don't make ApoE very well for genetic reasons, then these things are going to be higher in your bloodstream. Even though the person's diet is pretty good, you still see this very unusual blood panel. And then the VLDL is synthesized in the liver. It contains apoprotein B-100. It obtains ApoE and ApoC2 from HDL, as we said earlier, but it's that Apo B-100 that ends up on the LDL cholesterol that really helps the LDL cholesterol get cleared from the circulation. But over time, the apoprotein B-100 sort of dissociates from the LDL, and now it's harder for peripheral tissue to pick it up. So it either gets picked up by the macrophages in the atherosclerotic plaque, or slowly over time it gets cleared by the liver because it still has some ApoE on it. So remember that the remnant particle of all of this is the LDL cholesterol. So the LDL is primarily has this Apo B-100 on it that it inherited from the VLDL, and that it's the apoprotein B-100, as you'll see on its outer shell, that enables it to bind tightly to the LDL receptor to be cleared from the bloodstream via the LDL receptor. But the LDL receptor, the LDL particle cannot cross the blood-brain barrier, so you can't deliver cholesterol to the brain via the LDL. Whereas the HDL can cross the blood-brain barrier and bring some cholesterol into the brain, but for the most part, the brain makes its own cholesterol. This is an important fact because when you block cholesterol production with statin drugs, you're blocking cholesterol production in the liver, but you're also blocking cholesterol production in the brain. And the brain needs cholesterol for internal signal transduction reasons and to make a normal cell membrane. So you now see one of the black box warnings on statin drugs is that it can cause memory loss that's reversible if you go off the statin drug. So this is a concern about statin drugs as one of the potential side effects, because you're blocking cholesterol production, when the brain actually needs cholesterol. So the LDL cholesterol, as I said earlier, once it gets into the other cells of the body, it's going to be used to make the cell membrane, to make steroid hormones in the adrenal glands, the testes, and the ovaries. The skin will convert into vitamin D upon exposure to a certain wavelength in ultraviolet light. And also it gets converted to bile acids in the liver. So hang on to those particular facts. So here's how the LDL cholesterol gets cleared from the circulation. It has the apoprotein B-100 on its outer surface, which it inherited from the VLDL production, synthesis. So imagine if genetically you have a defect in making apoprotein B-100, you can't clear LDL very well. Or if you don't make this receptor, the LDL receptor, 1 in 500 people have trouble making this receptor. 1 in about, I think, 10,000 people have trouble making apoprotein B-100. We're going to see the numbers in a second. So these people genetically are prone to high cholesterol, even if their diet is good. Now, that's not most people, but that's a certain percentage of people where you have to have a tremendous amount of appreciation for the fact that in those cases, only drugs can bring their cholesterol down. But for most of us, we make apoprotein B-100, attaches to the receptor. It allows the receptor-mediated endocytosis to occur. So you bring the whole LDL particle into the cell, and then enzymes blow it apart. The outer protein on the outside gets, have amino acids that the cell can use. And the cholesterol gets stored and used for all the purposes that we talked about. In the meantime, the LDL receptor can recycle back to the surface. If the cell still needs more cholesterol, it can be used again. So in the bigger picture, and this is sort of the doctor picture that you should have, here's the LDL receptor on the cells. Here's how the LDL particle fits into the receptor with the help of the Apo B-100 protein. It gets internalized into the cell and forms this sort of coated vesicle. So here's the LDL receptor now being brought right into the cell. It encounters lysosomes, which blow it apart. The outer protein can be dissolved or digested, and now you have free amino acids in the cell to be used for all kinds of purposes, to make new proteins, and it releases this cholesterol. Now that cholesterol can be used to make the cell membrane and steroid hormones, bile acids, vitamin D, as we talked about. And the presence of that, some of that cholesterol can be stored for future use inside the cell. And the oversupply of cholesterol does two things. It shuts off the cell's own synthesis of cholesterol because now it has enough. And it also blocks the production of new LDL receptors. So once the cells have enough cholesterol, they shut off LDL receptor synthesis. And so now the extra LDL floats in the circulation and clogs arteries, basically. You can inherit certain genetic defects, but most of them are very rare. Like, let's say you don't make lipoprotein lipase, that's 1 in a million people. You don't make apoprotein C2 to clear those fats, that's 1 in a million people. These people have high triglycerides, eruptive exanthomas, fat gets lodged in their liver and their spleen, they get pancreatitis. Other defects of the Apo A, this is that you can't make chylomicrons, 1 in a million. It's not that common. But as we come to here, people who can't make apoprotein E very well. Well, that's 1 in 10,000 people. Oh, so now you can't clear chylomicrons very well and VLDL very well. So now you end up with you have high triglycerides and moderately elevated cholesterol. Or you don't make LDL receptors, right? An LDL receptor defect. 1 in 500 people. This is common. This is common. Or you don't make apoprotein B-100. 1 in, that says 1,000 people. I think I quoted 10,000. It's only 1 in 1,000 people. So these are the most common genetic defects that drive people's cholesterol levels up because you can't clear LDL cholesterol. So you keep making it and making it, but you can't get it out. The peripheral tissues can't pick it up that well. Even the liver can't pick it up that well. So these people can be thin, they exercise, they eat a healthy diet, and they've got cholesterol levels at 8.6, 9.2, 7.3. You're like, what are you eating? Oh, maybe it's because you had that small little pat of butter 4 weeks ago. No, that's not the reason. These people, when you see sky-high cholesterol like that in an otherwise fairly healthy person, it's genetic for the most part. So that's where you have to draw the line between what you can do in terms of nutritional counseling and where nutritional counseling needs also the aid of drug therapy. So these are eruptive exanthomas, especially where there's a lot of triglycerides and or high cholesterol. You've seen these in people. These are sort of telltale signs that they should be going to have their cholesterol, glucose, and triglyceride levels evaluated. So the truth is there's no way to know if you have an LDL receptor defect or an apoprotein B-100 defect or an ApoE unless you get your blood work done. You can't just assume that the person, because they're eating healthy and they exercise and they're thin, is, they're great. They're good to go. Oh, he was so healthy and fed and he was running a marathon and he dropped dead. Of course, he has high LDL cholesterol for genetic reasons. That's going to happen. You can't outrun it. It's not something where physical fitness can overcome this kind of clogging of the artery. It might slow it down a little bit, but eventually, if you have a severe homozygous LDL cholesterol defect, you got a problem. So the mutations that can lead to the LDL receptor defect can occur in different genes that affect the endoplasmic reticulum, synthesis of the receptor, the transport to the Golgi body, the LDL's ability to bind to the receptor, the internalization of the LDL receptor particle. Any one of these defects leads to an LDL receptor problem. Well, you can't clear LDL from the bloodstream. So 1 in 500 people have the homozygous form of this, where they just have their LDL receptors are just not made properly. They don't get transported to the surface properly. They don't work properly at the surface. They're just not configured properly. Or they have there's an Apo B-100 problem where the LDL can't attach to the receptor very well. 1 in 1,000 people. So under normal circumstances, atherosclerosis occurs this way, the sort of the view from 30,000 feet. First, you have endothelial cell damage, denuding of the endothelial lining. Then you have adhesion molecules, platelets coming to the area, and monocytes and other T lymphocytes. And the monocytes morph into macrophages. They go into the subendothelial space. They start to ingest LDL cholesterol, especially if it's oxidized LDL cholesterol. So the person's a smoker and they're oxidizing their cholesterol. See, the uptake is even faster by the macrophages. And that forms those lipid-rich foam cells, which leads to the fatty streak and plaque formation with, advancing occlusion of the artery over time. So for most of us, how do you get your cholesterol into the ideal range without drugs? Well, 90% of us can do that. The first part of the template is to avoid foods that are high in long-chain saturated fats, trans fats, deep-fried foods, and or there's too much cholesterol in the food to begin with, like eating organ meats. So this means avoiding or eliminating all beef products, all pork products, lamb and duck, organ meats, which are really high in cholesterol, any milk or yogurts that's 2% or higher. You want to stay with 1% or less. Any cheese is above 4% milk fat or 3% milk fat. That's almost every cheese. There's a few exceptions. Avoiding butter, cream, ice cream, whipped cream, regular chocolate products that have cocoa butter. That's different than sort of dark chocolate, which has a little bit of saturated fat. Like it's an occasional treat. That's probably okay. Palm and coconut oil are loaded with saturated fat, and don't think that it's all medium chain triglycerides that don't do damage. Most of the fat in coconut oil and palm oil are long chain fatty acids that do raise cholesterol. We'll come back to that. High fat pastries. Remember that one egg yolk has 250 milligrams of cholesterol. So the Dean Ornish, who's like the expert on heart disease, would say you should try not to have more than 150 milligrams of cholesterol on any given day. So if you have 3 eggs, that's 750 milligrams of cholesterol. Now, some people, when they eat eggs, whole eggs with egg yolk, their cholesterol doesn't really rise that much. And other people, when they have eggs, their cholesterol rises significantly. So some people are hypo-responders, some people are hyper-responders. But in no case, when people eat egg yolks, does their cholesterol go down. And most people would benefit from their cholesterol going down. So I personally have egg whites. I don't have the yolk. You can do whatever you want. Mayonnaise, hollandaise sauce, creamy salad dressings, French, ranch, blue cheese, all these ridiculous, disgusting salad dressings are not to be eaten. Extra virgin olive oil, not only is it good, but the flavonoids help to decrease oxidation of LDL cholesterol, as well as other oils that are higher in monounsaturated fats or omega-3 fats. Avoiding deep fried foods, you know what they are. Cream sauces and rosé sauces, on pastas and things, out the door. So more specifically, let's get specific, because this is really what it takes, is that most cakes other than the angel food cake have a lot of saturated fat, especially the frosting. Donuts and other pastry, crullers, Danish, cream puffs, chocolate eclairs, pie crusts, milk chocolate bars in a confectionery store. Most muffins are high in fat. There's some exceptions. Some muffins only have 2 grams of saturated fat. You might just want to eat the top of the muffin, make your own that are low in fat. Most biscuits, pancakes, depending on how they're made, French toast, all beef products, all that red meat, out. All pork products, out. Lamb, out. Organ meats, out. Butter and large, out. Cream and ice cream, I'd say twice during the summer I might go to Dairy Queen and have a small cone because it's ice milk. So it's sugary, it's going to raise insulin, that's not good. But at least the fat content is lower. Any milk or yogurt that's above 1% milk fat, it's going to raise your cholesterol levels. Any cheese above 3% palm oil and coconut oil. And remember that a lot of these new plant-based alternative meats, like the plant-based burger, is loaded with coconut oil, as you're going to see, and will raise your cholesterol levels. Some of the other veggie patties and like Eve's products and other great vegetarian patties and hot dog substitutes and ground round and textured vegetable protein, they're great. But this movement towards these new plant-based alternatives are loaded with coconut oil. So you have to look at ingredients now. Also shortenings on some breakfast cereals you have to watch, potato chips, cheesies, and all of that stuff. There are lower fat alternatives like crispy minis and skinny popcorn. There's some things that are lower in fat that are decent alternatives. Movie popcorn, of course, is high in fat. Low fat, saturated fat also implies no cream sauce, no tahini sauce. Tahini, loaded with saturated fat. Creamy salad dressings, the consumption of mayonnaise, deep fried foods, battered foods, breaded foods, all of those that we talked about. There's a bit of saturated fat or some of the bad fats in chicken breast and turkey breast and Cornish hen and soy products, but it's pretty low. So for most people, you can get away with that. If you're in a high risk category, I'd suggest you avoid those as well. There's no fat in egg whites, beans, peas, whey protein products. These are great sources of protein. Some of the healthier fats that you would like to include in your diet in small amounts, ultra virgin, extra virgin olive oil, avocado, fish and fish oil, flaxseed oil, nuts and olives. Just don't have large quantities because the total fat is high. A little bit of peanut butter, maybe hummus. I mean, you have to have some fat. So to lower cholesterol, the idea is then to take those bad fats out and put in things that are more acceptable. So for most people, if they don't want to go the full vegetarian or vegan route, then, chicken breast, turkey breast without the skin, Cornish hen, fish a couple of times a week. I wouldn't have it more than that because of the mercury risk. Egg whites, milk or yogurt or kefir that's 0% or 1% milk fat, cheese under 4%, whey protein products, or even soy or pea products or casein protein, anything that's good protein without the fat. And soy-based products, all these different soy-based products are great. Not only is it an alternative to protein that would be higher in fat, like beef or pork, but soy has its own independent cholesterol-lowering effects by blocking the absorption of cholesterol and bile acids from the intestinal tract. And beans and peas, not only do they have a good source of protein, but they also drag cholesterol out of the body as like bile acid sequestrants. Also, the things that actually increase the excretion of cholesterol from the body are eating peas and beans. There's soluble fiber in these foods, and also soy products, as I said. Having 1 to 2 heaping tablespoons of ground flaxseed every day, a third of a cup of oat bran, certain fruits and vegetables that are very fibrous, that have pectin fiber, lowers cholesterol, psyllium husk fiber. So how does soluble fiber lower cholesterol? It binds to bile acids and cholesterol in the gut and drags them through the intestinal tract so they can't be reabsorbed. Most of the time, about 80% of your bile acids normally get reabsorbed from the intestinal tract, go back to the liver so the liver can use the bile acids again. But if you have a magnet in your intestinal tract, like peas and beans, ground flaxseed, oat bran, apples, peaches, pears, psyllium husk fiber, they bind to the bile acids, so they can't get reabsorbed. So you drag them through the intestinal tract and you excrete them when you have a bowel movement. And so now the liver doesn't have its bile acids. So now the liver is going to clear more LDL cholesterol from the bloodstream and convert that cholesterol into bile. So now you're pulling LDL cholesterol out of the bloodstream. You convert it into bile. It gets excreted into the intestinal tract, and the soluble fiber drags it out, so you don't reabsorb it. So you're basically pooping out LDL cholesterol that was in your bloodstream a day ago as now bile acids going into the toilet. So that's how soluble fiber works. So based on that model, the drug companies invented what are called bile acid sequestrant drugs like cholestyramine, but they just basically work like these foods. Also, artichokes lower cholesterol. We're going to look at artichokes in a second. So do almonds. There are lipid-lowering drugs. We don't have time in this discussion to get into how they all work. But of course, statin drugs block cholesterol synthesis in the liver, so you can't make the VLDL in the first place. So now the fat gets stuck in the liver, but you don't produce cholesterol. So now you're at risk for fatty liver degeneration, memory loss, because you're blocking cholesterol production in the brain, and it can also cause muscle pain, as you'll see. Bile acid sequestrants, they work like soluble fiber, and fibric acid derivatives and niacin help to increase the activity of lipoprotein lipase so you can clear more triglycerides out of the bloodstream from the chylomicrons and the VLDLs, where people have defects in those areas. But there are cholesterol lowering supplements like gum google and artichoke leaf extract, which I want to explain to you right now. So in India, they have a tree called the mucalmir tree, and it gives rise to this resin called gum google or goo-goo lipid, which has been shown at a standardized grade to help increase more LDL being extracted from the liver and converted into bile and excreted through the biliary tract. So it can lower total cholesterol by up to 27% and triglycerides as well by up to 30%, improving the HDL to LDL ratio, a very non-toxic product. So in 2007, this great review in Cardiovascular Drug Reviews was published saying that in 1986 in India, they approved gum google as a drug for lowering triglycerides and cholesterol. About 70 to 80% of people respond very well to it. And about 20 to 30% of people, they don't. And that's because they have a genetic defect that's so strong that this type of intervention is not going to have a major impact. But for most people, it works. So one of the things that it does really well is it tends to increase more cholesterol being extracted by the liver. The LDL gets extracted more efficiently by the liver cells, and then it converts that cholesterol into bile acids, and it pumps it out into the intestinal tract so you can excrete it with a bowel movement. So it increases LDL catabolism, and then by inhibiting certain feedback enzymes, it allows more of the cholesterol to become converted into bile acids, as I'll show you. So let's go to the next slide. It also increases the pump that pumps more bile acids through the biliary tract, so you get a greater amount of excretion of bile acids with each meal and with each bowel movement. So you can increase your fecal excretion of bile acids by 57% by upregulating this pump in the liver that increases the amount of excretion of bile acids through the fecal route. Gum google also decreases oxidation of LDL cholesterol, which means less of it's going to be picked up by the macrophage and forming foam cells. And it has a slight effect on increasing HDL, which is fantastic in about 60% of people. And it decreases the synthesis of inflammatory cytokines from the macrophages in the arterial plaque. So it has all these great benefits on atherosclerosis. But here's how the bile acid story plays out. Once the LDL cholesterol gets picked up by the liver, right, and Google sterones help do that, gum google helps to do that, it also increases the activity of the 7-hydroxyhydroxylase, which converts cholesterol into the bile acids. Now, normally as these bile acids build up, there's a feedback molecule that blocks more of the conversion of cholesterol to 7-dehydrocholesterol. But gum google prevents that from happening, as you'll see in the next slide, Gugu lipid or gum Google increases the conversion of cholesterol to bile acids. So not only do you take more LDL out of the circulation, but you convert more of it to bile. Then you pump more of the bile through the biliary tract, so you excrete more of it with each bowel movement. At each meal, you're getting more of it into the intestinal tract. So you can lower cholesterol quite effectively through these different mechanisms. In terms of adverse side effects, some people, it has a very high level of safety, first of all. For some people, they get some GI upset if they use gum Google, and about 9% of people might show up with cutaneous skin rashes. That's the biggest concern. A person uses gum Google and they get sort of a skin rash. They can't use it anymore. That's the end of the story, unfortunately. The important thing about drug-nutrient interactions is simply that you don't use gum Google at the same time you're putting other drugs into your body, because it can change their biotransformation and their bioavailability. So you would just take gum Google at a separate time than you would be taking other medications, and you're completely fine. You don't use it in children, pregnant women, lactating women, because the safety is not known. Artichoke leaf extract is phenomenal as well. In a double-blind study, shown to lower total cholesterol by about 19% compared to placebo at 8%, and LDL cholesterol by 23% compared to 6%, and improves the LDL to HDL ratio. It also increases bile acid secretion by the liver. So more bile, you get a greater amount of bile flow through the biliary tract. So now more LDL cholesterol will be picked up by the liver cells. So you have your LDL levels coming down. So in a 2016 article that was published recently, where they looked at artichoke studies in diabetic rats, they showed a number of things that were quite fascinating. Reducing total cholesterol and LDL by converting the cholesterol into bile in the liver, sort of similar to what gum Google does, and also excreting it. Also inhibiting cholesterol synthesis to some degree, and inhibiting cholesterol absorption from the gut the way that soy products do. Acts as an antioxidant to decrease LDL oxidation. It also has a liver protective effect, which is very nice, because a lot of people are developing now non-alcoholic steatohepatitis or fatty liver degeneration. 25% of people in the world now have fatty liver problems. And in diabetic rats, it also lowered their blood sugar, their blood glucose, and their triglycerides, which was a phenomenal finding. So these are the active constituents of artichoke leaf extract. So if you're going to take, it's great to eat artichokes as a food, and it's something I try to do regularly. But if a person has high cholesterol, then you might want to combine artichoke leaf extract with gum Google to get a real super powered cholesterol lowering effect, which we did here at Adeeva. I'll show you that in a moment. So these are the dietary applications for artichoke consumption, whether it's food or supplements, to help lower cholesterol and reduce blood glucose, support liver health, boost antioxidant defenses. Artichokes are one of the world's highest foods that are most greatly enriched with antioxidant substances. And when you look at this antioxidant sort of scale or index, artichokes are right at the top, believe it or not. You think it'd be like oranges or something, but it's actually artichokes. And I also have a lot of dietary fiber, which helps with the excretion of cholesterol. They're very low in calories, but they're very filling. They can, instead of using starches at a meal, if you want to lower your glucose levels as well, use artichoke and give you that satiety. I add them, if I make a bean salad, I add artichokes to it with some olive oil and a little bit of vinegar. And though all those things combined are a great cholesterol lowering food. I mean, that's a cholesterol lowering medicine if you think about it. So we made here at Adeeva Chole Forte. It used to be called Cholesterex, but then the government made us change the name. It sounded like too much of a claim. So, but what it contains is the standardized grade and dosage of both gum Google and artichoke leaf extract that the human clinical studies have shown are effective at lowering the total cholesterol and the LDL cholesterol and raising the HDL. And for about up to 80% of people, this is a very, very effective supplement that doesn't have the side effects that some of the drugs do. I'm not saying that there are certain people that need those drugs, don't get me wrong. But in otherwise healthy people whose cholesterol is trending upwards, who don't have serious LDL receptor defects or other major genetic problems. That's most people don't have those problems, or they don't have atrial fibrillation. They're not already a cardiovascular patient because they had a stroke or heart attack, bypass surgery, or angioplasty, had a stent put in. They have, chronic kidney disease. If they're not those people, then, people can lower their cholesterol naturally, and this can be part of the solution for them, ought to be part of the solution. So just to reinforce some of the points I was making earlier, this is Dr. Catapano. A lot of people don't think cholesterol and saturated fat is a real issue around heart disease. And I was going to tell you that, the evidence really suggests otherwise. So this is Dr. Catapano, who's the president of the European Atherosclerosis study, saying that high LDL cholesterol is a main culprit, not the only culprit, but a main culprit for heart disease and cardiovascular disease. And diet and lifestyle should be the first line of defense. Not drugs. This is the first line of defense for most people. You need an LDL cholesterol that's under 1.8 millimoles per liter. Men are twice as likely to die from sudden death, heart attack than women. Men 45 to 70 have a 10% risk. Women have up to 3.5% risk. But as your risk factors increase, your risk of sudden death, heart attack increases. High LDL is one of those factors. This is in 2016 in the British Medical Journal. Very large study, the health professionals follow-up study following over 100,000 male and female health professionals. 18% greater risk of heart disease in the group consuming the highest amount of saturated fat compared to those having the least amount of saturated fat. Study also showed that certain types of saturated fat are riskier. So particularly lauric acid, myristic acid, and palmitic acid, these long-chain saturated fats. So beef products are high in palmitic acid, so are pork products, so are hot dogs, salami, bacon, sausages. This is heart disease promoting fat. Milk is very high in myristic acid. All the dairy products are high in myristic acid and also palmitic acid, also making them a significant danger. Coconut oil, which is very popular these days. A lot of people are under the impression this is some kind of healthy food. I don't know how this happened, but it's 48% lauric acid, 16% myristic acid, 9.5% palmitic acid. It's almost entirely fat, and 74% of the fats in there are heart disease promoting fats. When people replace the fats for like beef and high fat dairy and coconut with plant-based proteins like soy products and peas and beans, or they have more polyunsaturated fats, there's an 11 to 12% reduction in risk of developing heart disease. Other studies clearly show that lauric acid, myristic acid, and palmitic acid raise cholesterol levels. Coconut oil studies in humans. So recently they said, let's just put this to the test. And they did coconut oil studies in humans showing that it raises LDL cholesterol quite significantly versus other vegetable oils that are much lower in saturated fat, like avocado and other vegetable oils. So when you have these other oils that we would consider to be healthy, monounsaturated fats, polyunsaturated fats, omega-3 fats, don't they also travel in chylomicrons? Doesn't the liver also have to make VLDLs to transport them out of the liver? Yes. The difference is that those good fats turn on the production of more LDL receptors by the liver cells. So the LDL that's not needed by the peripheral cells in the body can easily be picked up by the liver and cleared from the circulation. Whereas saturated fats and trans fats and deep fried food and battered foods and breaded foods don't increase the LDL receptor synthesis by liver cells, so the extra LDL stay in the circulation and get incorporated into the blood vessel wall, forming atherosclerotic plaque. And that is the difference. Dean Ornish, one of my heroes, wrote the book on reversing heart disease, an MD at Stanford University, takes these high-risk people with advanced occlusion in their coronary vessels. He's been able to show an angiogram and other types of imaging in certain candidates who are qualified for his program. He's been able to reverse atherosclerosis and open up the artery wall through his program, which is basically a vegan or plant-based diet with a little bit of non-fat dairy products, egg whites, some nuts and avocado. He includes lots of soy products as a source of protein. And he's also saying this also helps to reduce risk of cancer, by the way. So he did a trial in men that had localized prostate cancer. I may have shown this to you earlier, where he actually helped to lower their PSA over the course of a year, put him on the same kind of dietary program. Dean Ornish has really helped us understand what a really healthy diet and lifestyle program ought to look like in our society, in my opinion. Now, just so you know that I know that high cholesterol is not the only risk factor for heart disease, I've listed for you what a proper cardiovascular risk profile should look like on any given patient. These are, we don't have time to get into this today. We can do this as a separate webinar. But these are all the things you want to know. What is their total cholesterol? What are their triglycerides? What's their homocysteine level? What is the INR? How sticky is their blood? What's their blood pressure? Do they smoke? What's their HDL cholesterol? What's the total cholesterol to HDL ratio? What's their family history of heart disease? How old are they? What's their gender? What's their activity level? What's their waist circumference? How much stress? What's their stress index? Are they a diabetic or pre-diabetic? What's their fasting glucose? What's their C-reactive protein? What's their fibrinogen levels? Also a factor for stickiness of the blood. What's the fructosamine level? How much are they sugar coating their proteins or their hemoglobin A1C? What's their uric acid level? Do they have metabolic syndrome? What's the LDL cholesterol particle? What's their kidney function? People with chronic kidney disease usually die of heart disease. You have to know their kidney function as well. Do they have a previous history of cardiovascular interventions or like a stroke, a heart attack? Have they had a procedure, a bypass surgery, angioplasty, stents? You have to know all of that to really get a cardiovascular risk profile. Today, we're just talking about cholesterol only, but it's not the only risk factor. But it is a cardinal risk factor. It's a significant one that should not be ignored. How do statin drugs work? Well, in the liver, I said that when fats arrive in the liver, you turn on cholesterol production from acetyl coenzyme A. Statin drugs work by blocking the HMG-CoA reductase. So you stop, you have this blockage here, so you can't form more cholesterol. But this is also how you make coenzyme Q10, also known as ubiquinone. This is the primary way the body makes CoQ10. So when you take statin drugs, not only are you blocking cholesterol production and trapping fat in the liver and stopping cholesterol production in the brain, but you're also blocking the synthesis of coenzyme Q10. And as a result, a lot of people end up with muscle pain from statin drugs. About 11% people think it's higher than it's up to 25%. 4% have severe muscle pain with it. And when people exercise, the muscle pain gets worse. So in recent years, this is something to know that for your patients who are on statin drugs, there are 3 vitamins or nutrients when supplemented have been shown to decrease muscle pain: CoQ10, vitamin E, and having the right blood level of vitamin D. So the reason that these vitamins are helpful is because statin drugs not only block the synthesis of cholesterol, but they also block CoQ10 synthesis, as I said. A decrease in CoQ10 inhibits energy production inside the mitochondria, the muscle cell, and also with that, more hydrogen electrons leak out of the mitochondrial membrane, so you have free radicals forming, which cause muscle damage, which also produces inflammation. So you get mitochondrial dysfunction, and you start to have the muscle membrane starts to leak things out into the environment. When you exercise, because more hydrogens are leaking out faster, there's a greater amount of leakage through the cell membrane, and you start forming more free radicals and you get more pain. The increase in free radicals that occur in the muscle from statin drugs causes an efflux or an exiting of the amino acid glutamate out of the muscle, and glutamate stimulates pain receptors and you get more pain. Studies show that by taking vitamin E supplements, because it's an antioxidant, it quenches the free radicals and less glutamate leaks out of the cell. And so vitamin E gives muscle cells more antioxidant protection to quench or neutralize free radicals generated by statin drugs. As such, muscle cells don't feel the need to pump glutamate out of the cell to produce more glutathione, which is an so the cell's not trying to make more glutathione because it has vitamin E to actually help itself as an antioxidant. Also, suboptimal levels of vitamin D below 75 nanomoles per liter, right? You need to get your vitamin D blood level for many reasons. At or above 75 or 80 nanomoles per liter, vitamin D is required by the muscles on many, many levels. So it's not a surprise that low vitamin D increases risk of statin-induced muscle pain. And people who are on the statin drug because they're not making CoQ10 need at least 90 milligrams a day of CoQ10 to make the CoQ10 their body's not able to make. You need a blood level of vitamin D at 75 nanomoles per liter. So vitamin D supplementation, at least 1,000 IUs for most people is going to be helpful. So that's why if people are on statin drugs, I would really encourage you to put them also on the Adëeva multivitamin. So they get the 400 IUs of vitamin E, the 1,000 IUs of vitamin D. They get the B50 complex to keep homocysteine down. They get calcium and magnesium at good doses to help keep their blood pressure down as well. And they have selenium, which has been shown in a number of studies now, along with CoQ10 to decrease risk of congestive heart failure as people age. These are cardiovascular benefits from this particular supplement. On statin drugs, it makes total sense. Here's the rest of the multivitamin formula. I know you've seen it before, so I won't bore you to tears with it. But it's a all high potency, full spectrum multivitamin. Along with cardio essentials, if they're on statin drugs, so you need to get them the CoQ10. So if they're on a statin drug, you're going to give them 3 capsules a day of cardio essentials. In my view, it also comes with hawthorn to help energy production in the mitochondria and quercetin to keep blood vessel inflammation and muscle inflammation down. And of course, there's our cholesterol lowering Chole Forte with the gum google and artichoke leaf extract that can be used in conjunction with statin drugs. It's not either or. If the person's on a statin drug, you can still give them this to bring their cholesterol down more effectively and maybe enable the doctor to give them a lower dose of the statin drug, which would be nice because the statin drugs come with risk of side effects. Liver damage, increased risk of type 2 diabetes in about 1 in 250 people, memory loss, muscle pain, and in very rare cases, life-threatening rhabdomyolysis, which is, chunks of protein leaving the muscle, clogging up the kidney tubules, and you go into sudden kidney failure and you die. So that doesn't happen very often. With some of the earlier statin drugs, the early ones that were used, that was a more frequent side effect, much less common now. Nevertheless, if a person doesn't absolutely need to be on a statin drug, I think you should show them the way out through diet, exercise, supplementation, and help people get to the mark. So it helps if you know what their numbers are, their total cholesterol, their LDL cholesterol, their HDL, and the total cholesterol to HDL ratio. Just knowing that gives you a framework in terms of what dietary modification you might want to be suggesting to people. So on that note, I hope that you'll follow this advice yourself, as I have, and I cheat a little bit, but I've been able to keep all my cholesterol, glucose, homocysteine, triglyceride, all those markers in the ideal range to prevent cardiovascular disease. So it's not an easy thing to do, but I think it's a very worthwhile thing to do if longevity and healthy life expectancy is sort of on your radar. So on that note, I will thank you very much for attending.